Pelvic, Hip, and Thigh Anatomy, Chapter 16. The pelvic girdle is a bony ring. This bony ring is formed by two innominate bones. These are what most of us refer to as our hips. An innominate bone is a nameless bone. In the pelvic girdle, the innominate bone is made up of three distinct bones: the ilium, the ischium, and the pubis. In addition to the two innominate bones, the sacrum and the coccyx are included in the pelvic girdle. The pelvic girdle is a basin-shaped complex of bones that connects the trunk and the legs. It supports and balances the trunk and contains and supports the intestines, the urinary bladder, and the internal sex organs. The pelvic girdle consists of paired hip bones connected in the front by a pubic symphysis and behind at the sacrum. Each is made up of three bones: the blade-shaped ilium, which is above and to either side and accounts for the width of the hips; the ischium, which is behind and below, on which the weight falls in sitting; and the pubis in the front. The anatomy of the pelvic girdle will be illustrated in the next few slides. The circles in red indicate the anterior superior iliac spine. The ASIS can be palpated easily if you stick your hands on someone else's hips and let your hands rest on the iliac crest. Where your thumbs naturally fall is most likely the ASIS. They typically stick out in most people and are a great place to bump into things. Therefore, you may have a bruise occasionally on your anterior superior iliac spine. The circles in red indicate the anterior inferior iliac spine. The AIIS is not easily palpated. The AIIS is deep. The best place to palpate the area for the anterior inferior iliac spine is in the leg crease where the thigh and the hip meet. The anterior inferior iliac spine is underneath some large muscles and tendons in that area. The circles in red indicate the posterior superior iliac spine. The PSIS are easily palpated. When you lift the back of your shirt up, you will most likely see two dimples in your lower back. These dimples are typically where the PSIS are located. The circles in red indicate the posterior inferior iliac spine. The PIIS are not easily palpated as they too, like the anterior inferior iliac spine, are deep to other tissues. The red circles indicate the area of the posterior inferior iliac spine, but they are not visible in this picture. We would need a picture of the posterior surface of the pelvic girdle to see the posterior inferior iliac spine. The lines in red indicate the iliac crest. The iliac crest is easily palpated. Every time you put your hands on your hip, you are palpating your iliac crest. The arrows in red indicate the ischial tuberosity. The ischial tuberosity are sometimes referred to as sit bones. The ischial tuberosity are easily palpated in the middle of the buttocks. It is easiest to palpate them if you lie on your side and put one knee up slightly, and then palpate in the lower part of your buttocks. You should feel a hard bone, which is the ischial tuberosity. This is where we bear most of our weight when we are sitting in a chair. The circles in red indicate the acetabulum. The acetabulum are not easily palpated as they are deep to other tissues. The acetabulum is the location of the articulation with the head of the femur, which makes up the ball and socket of the hip joint. The circles in red indicate the obturator foramen. The obturator foramen is not easily palpated as they are deep to other tissues. The obturator foramen is a large opening created by the ischium and pubis bones of the pelvis through which nerves and blood vessels pass. This is a lateral view of the structures we just identified. You can also see the three individual portions of the innominate bone. The yellow portion is the ilium, the blue portion is the ischium, and the red portion is the pubis. Here is a medial view of those same structures we just identified. Looking at the hips from different angles can help you to identify different structures more easily. The sacrum in human anatomy is a large triangular bone at the base of the spine that forms by the fusing of sacral vertebrae S1 through S5 between 18 and 30 years of age. The sacrum has three different surfaces which are shaped to accommodate the surrounding pelvic structures. Overall, it is a concaved or curved upon itself structure. The base of the sacrum, the broadest and uppermost part, is tilted forward. The central part is curved outwards towards the posterior, allowing for greater room in the pelvic cavity. The coccyx, commonly referred to as the tailbone, is the final segment of the vertebral column in humans. The coccyx is formed of either 3, 4, or 5 rudimentary vertebrae. It articulates superiorly with the sacrum. In each of the first 3 segments may be traced a rudimentary body and articular and transverse process. The last piece, sometimes the third, is a mere nodule of bone. The transverse processes are more prominent and noticeable on the first coccygeal segment. All the segments lack pedicles, laminae, and spinous processes. The first is the largest. It resembles the lowest sacral vertebrae and often exists as a separate piece. The remaining ones diminish in size from above downward. Most anatomy books incorrectly state that the coccyx is normally fused in adults. In fact, it has been shown that the coccyx may consist of up to 5 separate bony segments, the most common configuration being 2 or 3 segments. The femur or thigh bone is the most proximal or closest to the center of the body bone of the leg. The head of the femur articulates with the acetabulum and the pelvic bone, forming the hip joint, while the distal part of the femur articulates with the tibia and kneecap or patella, forming the knee joint. By most measures, the femur is the strongest bone in the body. The femur is also the longest bone in the body. Its length on average is about 27% of a person's height. This ratio is found in both men and women and across most ethnic groups. This is important and useful in anthropology because it offers a basis for reasonable estimation of a subject's height from an incomplete skeleton. The femur is categorized as a long bone and comprised of a diaphysis, the shaft, 2 epiphyses, or extremities that articulate with adjacent bones at the hip and the knee. The angle of inclination is formed by the angle resulting from the intersection of a line drawn from the long shaft of the femur and a line drawn through the neck of the femur. Typically, the normal adult has an angle of inclination between 120 and 125 degrees. An increase in this angle, greater than 135 degrees, results in coccyvalgia, and a decrease or less than 120 degrees is called coccygera. The angle is widest at infancy and becomes lessened during growth, so that at puberty it forms a gentle curve from the axis of the body to the bone. In the adult, the neck forms an angle of about 125 degrees with the body, but this varies with an inverse proportion to the development of the pelvis and stature. The angle decreases during the period of growth, but after full growth has been attained, it usually does not undergo any changes, even in older age. It varies considerably in different people of the same age. Coccygera and coccygvalgia have some physical presentations. Coccygera will result in a decreased angle of the hip-neck angle. The leg appears shorter. The patient will appear to have genu valgum, which is where they look like they are knock-kneed, and the patellas will squint, which means they ride high and kind of look at each other towards the midline. Coccygvalgia is the result of an increased angle of the hip-neck. The leg appears longer, and the patient will appear to have genu varum, which is where they look like they're bow-legged, and the patellas will have a frog-eyed appearance, which means they sit laterally and high on the knee. The angle of torsion is formed by looking at the relationship between the axis of the femoral head and neck and the femoral condyles. The normal femur has an angle of torsion between 12 and 15 degrees. An increase in this angle is termed anteversion, while a decrease in this angle is termed retroversion. It is important to note that both normal and abnormal angles of inclination and torsion are properties of the femur and exist independently from the hip joint. However, abnormalities typically alter the joint stability. Anteversion and retroversion will both have physical characteristics in much the same way as coccygvalgia and vera do. A patient with anteversion will suffer from femoral internal rotation. They will present with a squinting patella, where the 2 patella appear to be looking at each other and shifted towards the midline. The patient will also walk with a toe-in gait, which is sometimes referred to as being pigeon-toed. A patient with retroversion will suffer from femoral external rotation. They will present with a frog-eyed patella, where the 2 patella appear to be on the lateral surface of the knee and sitting high, and the patient will commonly walk with a toe-out gait, which is sometimes referred to as a duck or penguin walk. The innominate bones, the ilium, ischium, and pubis, unite in early adulthood at the triangular suture in the acetabulum or the cup-shaped socket that forms the hip joint with the head of the femur. The ring made by the pelvic girdle functions as the birth canal in females. The pelvis provides attachment for muscles that balance and support the trunk and move the legs, hips, and trunk. In a human infant, the pelvis is narrow and non-supportive. As a child begins walking, the pelvis broadens and tilts. The sacrum descends deeper into its articulation with the ilia, and the lumbar curve of the lower back develops. The pelvis is vital to both locomotion and childbirth. Natural selection has been confronted by two conflicting demands: a wider birth canal and locomotion efficiency, a conflict referred to sometimes as obstetrical dilemma. The female pelvis has evolved to its maximum width for childbirth. A wider pelvis would make women unable to walk. In contrast, the human male pelvis are not constrained by the need to give birth and therefore are much more optimized for locomotion or movement. The principal differences between male and female true and false pelvises include: a female pelvis is larger and broader than the male pelvis, which is taller, narrower, and more compact. The female inlet is larger and oval in shape, while the male sacratory prominent projects further. For example, the male inlet is more of a heart-shaped than the female. The angle between the inferior pubic rami is acute in men, about 70 degrees, but obtuse, about 90 to 100 degrees in women. The distance between the ischia bones is small in male, making the outlet narrow, but larger in females who have a relatively large outlet. The ischial spines and tuberosities are heavier and project further into the pelvic cavity in males. The greater sciatic notch is wider in females. The iliac crests are higher and more pronounced in males, making the male's false pelvis deeper and much more narrow than females. The male sacrum is long, narrow, and more straight and has a more pronounced sacral promontory. The female sacrum is shorter, wider, and more curved posteriorly and has less pronounced promontory. The acetabulum are wider apart in females than males. In males, the acetabulum faces more laterally, while it faces more anteriorly in females. When men walk, the leg can move forward and backwards in a single plane. In women, the leg must swing forward and inwards, where there is a pivoting of the head of the femur moving the leg back into another plane. This changes the angle of the femoral head, giving the female gait its characteristic or swinging of the hips. The hip joint is a synovial joint formed by the articulation of the rounded head of the femur and the cup-like acetabulum of the pelvis. It forms the primary connection between the bones of the lower limb and the axial skeleton of the trunk and pelvis. Both joint surfaces are covered with a strong but lubricated layer called articular hyaline cartilage. The cup-like acetabulum forms at the union of the three pelvic bones, the ilium, the pubis, and the ischium. The Y-shaped growth plate that separates them is fused definitively at age 14 to 16. It is a special type of ball and socket joint where roughly the spherical femoral head is largely contained within the acetabulum and has an average radius of curvature of 2.5 centimeters. Because so much of the head of the femur is articulating with the labrum, there is a greater stability but less range of motion when comparing to the shoulder joint. The acetabulum grips almost half of the femoral ball, a grip augmented by the ring-shaped fibrocartilage lip of the acetabular labrum, which extends the joint beyond the equator. The head of the femur is attached to the shaft by a thin neck region that is often prone to fracture in the elderly, which is mainly due to degenerative effects of osteoporosis. The hip joint is reinforced by 4 ligaments, of which 3 are extracapsular and 1 is intracapsular or inside the capsule. The extracapsular ligaments are the iliofemoral, ischiofemoral, and pubofemoral ligaments that are attached to the bones of the pelvis, the ilium, ischium, and pubis respectively. All 3 strengthen the capsule and prevent excessive range of motion in the joint. Of these, the Y-shaped and twisted iliofemoral ligament is the strongest ligament in the human body. In the upright position, it prevents the trunk from falling backward without the need for muscular activity. In the sitting position, it becomes relaxed, thus permitting the pelvis to tilt backward into its sitting position. The iliofemoral ligament prevents excessive adduction and internal rotation of the hip. The ischiofemoral ligament prevents medial or internal rotation, while the pubofemoral ligament restricts abduction and internal rotation of the hip. The intracapsular ligament is the ligamentum teres. It is attached to a depression in the acetabulum and a depression of the femoral head. It is only stretched when the hip is dislocated and may prevent further displacement. It is not that important as a ligament, but it can often be vitally important as a conduit of a small artery to the head of the femur, that is the foveal artery. This artery is not present in everyone, but can become the only blood supply to the bone in the head of the femur when the neck of the femur is fractured or disrupted by injury in childhood. The pubic symphysis, or symphysis pubis, is the midline cartilaginous joint uniting the superior rami of the left and right pubic bones. It is located anterior to the urinary bladder and superior to the external genitalia. The pubic symphysis is a non-synovial ampiarthroidal joint. The width of the pubic symphysis at the front is 3 to 5 millimeters greater than its width is at the back. This joint is connected by fibrocartilage and may contain a fluid-filled cavity. The center is avascular, which means it does not have a blood supply. This is possibly due to the nature of the compressive forces passing through the joint, which may lead to harmful vascular disease. The ends of both pubic bones are covered by a thin layer of hyaline cartilage attached to the fibrocartilage. The fibrocartilaginous disc is reinforced by a series of ligaments. These ligaments cling to the fibrocartilaginous disc to the point that the fibers intermix with it. There is a slight movement available at the pubic symphysis. In normal adults, it can be moved roughly 2 millimeters and with 1 degree of rotation. This increases for women at the time of childbirth. This is a picture to demonstrate the large ligamentous support of the pelvic girdle from an anterior view. This picture is a demonstration of the large ligamentous support of the pelvic girdle from a posterior view. The hip bursa is a bursa at the top and outer side of the femur, between the insertion of the gluteus medius and the gluteus minimus muscles to the greater trochanter of the femur and femoral shaft. It has the function, in common with other bursa, of working as a shock absorber and as a lubricant for the movement of muscles adjacent to it. Occasionally, this bursa can become inflamed and clinically painful and tender. This condition can be a manifestation of an injury, often resulting from a twisting motion or from overuse, but sometimes arises from no obvious definable cause. The symptoms are pain in the hip region upon walking and tenderness over the upper part of the femur, which may result in the inability to lie comfortably on the affected side. The femoral triangle is an anatomical region of the upper inner human thigh. The femoral triangle is bounded superiorly by the inguinal ligament, medially by the lateral border of the adductor longus muscle, laterally by the medial border of the sartorius muscle. Its floor is formed by the pectineus and adductor longus muscle medially and iliopsoas muscle laterally. Its roof is formed by the fascia lata except for the spinous opening, where it is formed by the cribriform fascia. The femoral triangle is important as a number of vital structures pass through it right underneath the skin. The following structures are contained within the femoral triangle, from lateral to medial. This includes the femoral nerve and its terminal branches, the femoral sheath and its contents, the femoral artery and several of its branches, the femoral vein and its proximal tributaries, examples the great saphenous and the deep femoral veins, and deep inguinal lymph nodes and associated lymphatic vessels. The hip joint is supplied with blood from the medial circumflex femoral and lateral circumflex femoral arteries, which are usually both branches of the deep artery of the thigh. But there are numerous variations, and one or both may arise directly from the femoral artery. There is also a small contribution from the foveal artery, a small vessel in the ligament of the head of the femur, which is the branch of the posterior division of the obturator artery, and may become important to avoid avascular necrosis of the head of the femur when the blood supply from the medial and lateral circumflex arteries gets disrupted, for example during fracture of the neck of the femur along this course. The hip muscles act on 3 mutually perpendicular main axes, all of which pass through the center of the femoral head, resulting in 3 degrees of freedom and 3 pair of principal directions: flexion and extension, lateral rotation and medial rotation, sometimes referred to as external and internal rotation, abduction and adduction, and a combination of these movements, or circumduction.